مساء الخير، أهلا بكم في لقاء اليوم، وهو بورقة يقدمها الدكتور عبد السلام مصطفى، مقيم السنة الرابعة في مستشفى البصرة في بغداد في الجمهورية العراقية، وهي بعنوان Framework of Brain Derived Dimensions of Psychopathology من جامعة سايكاتري. تفضل دكتور.
تمام، شكرا دكتور. بالبداية أشكر يعني أستاذنا الدكتور وليد على يعني هذا الفلور المهم لمناقشة الجورنالز يعني بين الأطباء النفسيين العرب. طبعا the paper that we are talking about today is a very big paper. It has been published recently in 2025. It had a research team of more than 30 psychologists, psychiatrists, neuroscientists, and statisticians. It happened in a large sample with more than 1,000 patients with many data sets used. We'll go over them later on in the lecture. So this is a big research paper, actually, and going through the data will need us to cut through some neuroscientific and statistical jargon. Hopefully, I will keep it lightweight so we can know the psychiatric implications of this paper. So, going through to the overview and introduction, what is the main problem that the paper is trying to solve here? The main problem is with the traditional categories, with the nosology. We are all accustomed to it. The nosologies we find in DSM and ICD, these are rigid boxes, especially since DSM-3, we have been having operationalized definitions that are rigid. We have heterogeneous big entities like bipolarity, major depressive disorder, schizophrenia, and these boxes have many problems. The research team cite 4 problems, at least in the overview. One of them that there are major biological links with these entities. We don't have that much understanding of the biological substrates and circuits for these entities. The second problem that they are having is the comorbidity problem, a very common problem in the current nosologies. We have large comorbidity rates between these different entities, which can tell us that actually these entities are not that valid. Maybe they are reliable in the clinical setting, but that many of the entities have many shared mechanisms and things happening in the brain that is overlooked by these nosologies. So they are trying actually to quantify this comorbidity so we can understand that each patient, how much is he having from this problem and that problem. The third thing that they are citing, the third problem with the traditional categories, is that the objective means of
هل السلايد ما تحركت إذا أنت منتبه؟
نعم دكتور، وجاي أشرح عن السلسلة.
أوكي.
For objective means of patient stratification, they don't have objective means of stratification inside these nosologies. We usually don't do biological biomarkers, so we cannot understand how to stratify patients when we are treating them. And the fourth problem is that usually with no biomarkers, we need to treat these patients formulating them from outside of the nosology. That's where formulating from biological and psychological perspectives help us. So these problems with the traditional categories have pushed these authors and authors elsewhere to look out for another way of categorizing psychiatric problems or psychiatric diagnoses. So these are the limitations. We talked about the limitations. So are there other uh, other trials or frameworks hitting on this problem? Yes, there are two important ones, the RDOC and the HITOP. The RDOC, which is Research Domain Criteria done by the NIH, is working on a biological or behavioral about relating biology and behavioral processes and giving new categories that are not found usually in DSM and ICD. Also, another way to understand psychiatric diagnoses in another way is the HITOP, or the hierarchical taxonomy of psychopathology. This is more clinically driven. It is more like transdiagnostic symptoms, taking symptoms alone, and like we have fear. Fear is found in many entities inside DSM or ICD. This fear is dealt with as a transdiagnostic entity, and we treat and understand fear بمعزل عن these entities that we have in DSM and ICD. So what are the people in this research, the authors, what are they trying to do? They find a problem with RDOC and HITOP, that they are too far away from the ICD and the DSM nosologies. So what they are trying to do is to bring together a large set of brain data. We'll see the brain data they are using. They will be using more than 7 data sets from brain data and bringing them together with the DSM and ICD symptom lists so that they can get circuits that cut through DSM and ICD, but yet are easily recognized by the psychiatrists who are already accustomed to the ICD and DSM. So this is what are they trying to do. They are not trying to build something from zero like RDOC and HITOP. They are trying to use the same symptoms, the same checklists we are using in DSM and ICD, but then knitting these all together with the brain data they have from their patients and trying to give us new categories and new dimensions, which we'll be talking about. So the idea is that with brain-informed dimensions, brain-informed categories, we will be able to understand the circuits and we will have less comorbidity. We will try to link symptoms more diagnostically, and we will have better biological markers. And that will improve our interventions and improve our predictions. That is the main problem that the research paper is trying to solve or trying to help us solve. This is like first baby steps into the way. So the methods. Now, the method has much statistical jargon into it. I'll try to cut through it, but we should understand the steps that they did the research through. First of all, the sample. They had 2 large cohorts. The first one is Imagine cohort, which is reinforcement-related behavior in normal brain function and psychopathology. It had more than 1,200 patients. They included only 800 patients, 794. ليش؟ Because those patients, the 800 participants, had full data. They did all of the MRIs, they did all of the questionnaires. The Imagine cohort is population-based, so it has normal people and abnormal people. And it is longitudinal. That's very important. They did it at age 14, age 19, and age 23. So we have data going back to 2010, يعني أكثر من 15 سنة, in Imagine cohort. This is a longitudinal population-based cohort. 800 of them entered this research method. The other cohort, which is Stratify ESTRA, brain network-based stratification of mental illness or earlier detection and stratification of eating disorders. This other cohort is actually cross-diagnostic with abnormal people having eating disorders, having substance abuse disorders, having major depressive disorder, bipolar disorder. And this is cross-diagnostic, cross-sectional. There is 485 patients. Of them, 209 only completed all of the data sets, all of the MRIs, all of the questionnaires. So in total, we have 1,000 patients, 1,003, 800 from the Imogen cohort and 200 from the Stratify Estrapa cohort. These are the patients who completed all of the data needed for this research. So what is the data? What is the data, or what are the data that have been taken from these patients? We have clinical data and we have neuroimaging multimodal data. The clinical data have been taken through 3 questionnaires, and these questionnaires are important because they use ICD and DSM symptoms. The first one is DWBA, which is the Developmental and Well-being Assessment. The second one is the Strength and Difficulties Questionnaire, SDQ. And the third one is Audit, Alcohol Use Disorders Identification Test. The third one is quite common. Everyone knows about it. So the DWBA is, they are using the same phrases that are used in the DSM and ICD to take the symptoms. But I'll bet these are self-rating questionnaires. The second set of data are the multimodal brain data. So we have more than 7 modalities taken from patients. They did functional MRIs, they did task-based functional MRIs, they did diffusion MRIs, they did normal MRIs. So we had a large chunk of data from brain data relating to 3 big modalities of the brain. First of them is the structure. So we had cortical thickness, CT, cortical thickness. This is not CT, the imaging model, CT, cortical thickness. We had white matter fraction anisotropy and surface area. So we had 3 data sets relating to the structure of the brain, the surface area, the cortical thickness, the white matter fraction anisotropy. And we had a set of data related to connectivity, which is resting state functional MRI, which is the patient just resting without doing any task. And we had a third modality, which is functionality, the patient doing tasks that has certain functions while put inside the functional MRI. They did 3 tasks, start stops task, which is about set shifting. They did monetary incentive delay test, which is about having heightened motivation for incentive for longer periods, which is meaning that more MID then we are having someone who's heightened for reward more than normal. And also emotional face task, which helps with fear and understanding the emotions of people through their faces. So we had 10 set of data, 3 questionnaires and 7 brain imaging data. This goes through ICD, DSM, different criteria. These go through structure, connectivity, and functionality of the brain. This very big chunk of data that has been accumulated for more than 15 years for those 1,000 patients have been gone through an algorithm in the statistics called SGCCA. The SGCCA is sparse generalized canonical correlation analysis. Now, I don't want to go to the statistical nitpicks of this thing. Actually, I don't understand all of it, but taking this easily, CCA, canonical correlation analysis, is about having the linear correlation between 2 big data sets. So we have functional MRI and some kind of psychopathology. CCA tells us how much there is correlation between those 2 large data sets. Generalized means that we are doing more than 2 data sets. We are actually doing 10 data sets here, 7 brain imaging and 3 clinical. Sparse is that during doing the statistical analysis, some of the data which has low values is being zeroed so that we have less noisy data. That's we are sacrificing data. نضحي بالداتا حتى نحصل linear model of association. So SGCCA is a sparse generalized canonical correlation analysis. It is about having correlation between very big large data sets while keeping it lean, while trying to cut through the noise. Because if we have that much data, we have too much noise. So how did they train this algorithm to understand our psychiatric symptoms? They did that through 5 steps. The first step, they brought 70% of the imaging cohort. Let's remember, the imaging cohort is the longitudinal cohort that has been there for 15 years. They brought the last point, which is age 23. They brought 70% of them, and they trained the LGCCA statistical algorithm to pick up the dimensions of correlation between the clinical data and the um, the um, uh, the brain imaging results. So how did they train it? We'll talk about that in the next slide. So they trained it, and uh, uh, that brought us a chunk of dimensions that correlate between the clinical data and the brain imaging. Did they only do that؟ يعني هو هذا دراسة لوحده انهم سووا training على هذا الكوهورت الكبير اللي has more than 800 patients and they brought up some correlations inside this cohort. They actually didn't just do that. They tested the results and then validated them. Tested them on the remaining 30% of the imaging cohort. يعني احنا هذول ال 800 شخص اللي هم longitudinal اللي وصلوا لنا عمرهم 23 سنة، طلعنا الكوريليشن 70% من عندهم، بعدين شيكنا او تأكدنا من هاي الكوريليشن ب 30% من البقية اللي بنفس الكوهورت. ما اكتفوا بهذا الشيء، انه بنتقلوا الى الكوهورت اللي هو جاي من غير سناتر، اللي هو الستراتيفاي استرا 200 participants. يعني اصلا عافوا الموداليتي اللي كان موجود عندهم او الكوهورت اللي موجود عندهم، انتقلوا الى كوهورت اخرى من غير سياق ومن غير context, and they validated the dimensions that they had from the training and testing steps. So they confirmed generalizability. يعني هذا كأنما واحد سوى بحث ثاني حتى يسوي validation للنتائج اللي هم وصلوا لها، فهم سووا هاي العملية أصلا بداخل نفس البحث. بعدين يعني they took it furthermore. They did longitudinal analysis. They got back to the data from Imogen. We said that we had data from age 14 and age 19. They asked this question: these patients, when they were adolescent, in early adolescence and late adolescence, did they have the same brain? Did they have the same brain correlates with the psychopathology back in the early years of their psychopathology or even before the psychopathology? Did this stick even longitudinally? So they did that also. So this is not only a research. They did research on the primary cohort, then they tested it, then they validated it, and then they added longitudinal data, which is very robust, to be candid. So during this process, they resampled in many ways. We'll be talking about that in the next slide, and they produced correlation analysis. So yet again, we don't want to go to the statistical jargon, but I should, this is the method. So how did they train this model through these steps? They took the 3 clinical data views and the 7 imaging modalities. They corrected each of them for age, sex, and scanning site. So they got these confounders out of the way from the beginning. Then, during the training phase, they did the SGCCA algorithm, and it brought them 10 components, 10 big networks, 10 big dimensions, 10 big correlates between clinical data and brain imaging. يعني فد 10 مجاميع من الأشياء اللي مرتبطة كبرين imaging وك clinical data. And these 10 components explained 14% of cumulative variance. يعني قدرت تفسر لنا 40% من الاختلاف اللي موجود داخل هذا الكوهورت مال الايمجن. طبعا اللمدة اللي هو كمية السبارسيتي، انه ايش قد صفروا من القيم القليلة، فهنا صفروا بنسبة 30%. بعدين يعني ما اكتفوا بهذا الشيء، حتى يتأكدون من الروبست، يعني إنه هذا روبست الريزلتس مالتهم، سووا 10,000 ريسامبلينج ل 50% من المرضى بطريقة عشوائية. وهذا الريسامبلينج بطريقة عشوائية خلاهم يرجعون من جديد ويوصلون إلى نفس ال 10 components بالتيستينج that has been explaining أكثر من 50% من الفارينس، بس طبعا مع تصفير المزيد من الفاليوز. طبعا هذا كله صار بالتريننج فيز. بعدين من طبوه بالتيست فيز والفاليديشن واللونجيتيودينال ما بقى عندنا 10 الكومبوننتس، وإنما صار عندنا only 6 components that kept their significance in the next phases. So this is how the SGCCA worked inside this research. These are the methods. طيب هذا statistical jargon. Now going into the results. The results are important. We said that they got 6 dimensions. صار عندهم 6 dimensions, 6 networks, 6 groups of brain data plus clinical data. شنو هذا ال6 مجموعات وشلون عرفوهن؟ The first group is excitability impulsivity. طبعا هذا ال R is the correlation coefficient. We'll be talking about this later on. حتى نفهم أول dimension شنو السيمتومز اللي موجودة به اللي هو excitability and impulsivity. These are the questionnaires, the questions achieving more full of energy, more outgoing, active, jokes and loves more, اللي هي bipolarity أو المانيك phase of bipolarity. Poor concentration, excitable, distractible, talking fast, restless. So manic bipolar symptoms يعني in our DSM way of thinking, these are manic bipolar symptoms, excitability and impulsivity. And even as this radial diagram shows us that these symptoms are usually associated with the bipolar disorder in our current nosology. So the first dimension they found is excitability and impulsivity. And they found it to be related to the deactivation of the frontoparietal control network. So this network, the circuit that controls our way of doing our, inhibit our behavior and control our behavior, is deactivated or hypoactivated in excitability impulsivity patients who have these symptoms. So the main model things that they had is that the start-stop task has been negative for these patients. So they are not able to set shift easily. They can't inhibit themselves. They found also that the surface area of the dorsolateral prefrontal cortex and the anterior cingulate cortex and the inferior parietal cortex to be diminished. And this also goes with this problem being related to the frontoparietal control network. So the brain data says that this chunk of symptoms, we should be looking at these because we'll find bipolar symptoms, other bipolar symptoms and other dimensions. This chunk of symptoms is related to this circuit in the brain. And these chunk of symptoms are a brain phenomena that is validly distinct from other things. The other dimension that they had is depressive mood distress. Now, why didn't they only say depressive mood? They added distress because we'll be finding that some bipolar symptoms are related to this negatively in a certain way. It is like a switch between bipolar and major depressive disorders. So in a way that looks like a mixed major depressive episode. So even here with the radial diagram, we'll be seeing that these kind of symptoms are the symptoms that we find in major depressive disorder plus some aspects of the bipolar disorder. So this is a Kraepelinian idea. That means that in the brain, some of the bipolar symptoms and the major depressive symptoms are actually well knit, well connected. So where is the problem in this circuit? It is in the frontolimbic network. Now, the frontolimbic network is the network that regulates emotions. it is a top-down regulation of emotions. So here the frontal regulation of the limbic system is not intact. It is cut off. So we can see that the start-stop task is positive here, more positive than the excitability impulsivity. So this is like opposite to the excitability impulsivity domain. While the monetary incentive delay task, which is about having more incentive for rewards and sustaining reward taking behavior, is negative. So we have frontal, during these tasks, we have overactivation of the hippocampus and amygdala, the limbic structure, while we have the activation of the dorsolateral and medial prefrontal cortex and the posterior cingulate cortex, which are related to regulation. So this image shows us how the excitability impulsivity domain is antagonist to the depressive mood and distress. We can see that the stop signal task is deactivated in the excitability impulsivity. We have these deactivated parts of the brain, that meaning that the patient is not able to inhibit himself. While we have them more in yellow and red color in the depressive mood and distress, that means the patient is more inhibited than usual. So the third dimension, to go over them, is emotional behavioral dysregulation. Now, this is also a big problem. They found out that anxiety goes with poor concentration and poor learning. Let me show the symptoms. So we have distress of anxiety, irritability, insomnia, muscular tension. We have impact on family life of major depressive disorder, impact on learning, the pseudo dementia aspect of major depressive disorder. These same from the brain perspective, the symptoms of anxiety go with the cognitive and emotional disturbance found in other aspects. So when we look at this radial figure, we can see that this dimension occupies very much of our psychopathology in DSM and ICD. So this is the biggest one regarding the diagnoses, our diagnostic nosologies. And by the way, this is quite common sense لأنه احنا كل المرضى نشوف انهم يصير عندهم anxiety و emotional behavioral dysregulation as a result of their psychiatric problems. So this is not يعني مو ذاك الاكتشاف الكبير. بس الفكرة هي انه they found a distinct brain correlate for this consequence, which is the salient system and the ventral attention network. The salient system is related to this is the smoke detector. يعني هذا المكان، هاي المناطق من البرين اللي تعرف انه تخليك انتبه اكو فد internal or external cue that you should be looking at. Ventral attention network is related to emotional attention. So what is happening here is that the smoke detector of the brain is peeping because of acute emotional distress. So they found out that all of the functional modalities, the monetary incentive, delay test, the start-stop task, and emotional phase task, they found that salience structures and ventral attention structures are being activated in this psychopathology. This included the insula, amygdala, thalamus for the salience network, included the medial prefrontal cortex, which connects the salience network with the ventral attention network, and the superior temporal cortex, which is part of the ventral network. Most importantly here, النقطة المهمة الوحيدة الكلينيكال بهاي الهوسة النيوروساينتفك، انه المونيتري انسنتيف ديلي تاسك هنا بوزيتيف، فقدروا يطلعون فد circuit. هاي السيركت is related to anxiety and emotional dysregulation but is not related to depression. يعني مثل ما انه الدبريشن هو in opposition to the impulsivity excitability، السيركت هذه اللي هي الايموشنال behavioral dysregulation هي صايره ايضا opposite to the depressive mood and distress. فصار عندهم distinct circuits لبعض السيمتومز الدبرسيف و distinct circuit لسيمتومز اخرى depressive وموجوده بالانكزايتي. فهيك هذا يفيد، يعني هذا معناه إنه أكو في الطريقة بالبرين نقدر نفرق بيها بين الانكزايتي والدبريشن بطريقة معينة ومحددة. طبعا يعني هي ماكو فد treatment targets but there is something in the brain that is distinct. زين. الفورث dimension هو الستريس باثولوجي. Now the stress pathology they are actually talking about PTSD. When they are talking about stress pathology, they are talking about PTSD. This is the radial figure. Most of the symptoms are related to PTSD, flashbacks, being irritable, being alerted to danger, impact on leisure, and impact on friendship, and other symptoms. So this is related to trauma. The network that has been connected here is salience again. Salience is important. Salience is about having your psyche attending to something, but attending to what? In the previous dimension, we were talking about the ventral attention network, which is related to emotional attention. Here is the default mode network, which is related to the interoceptive and self-monitoring engagement. So this seems that there is heightened interoceptive and self-monitoring engagement under having stress and trauma. So they also had related to the salience network, insula and dorsal anterior cingulate cortex, and the default mode network is the pre and post central gyrus. Also, they had some structural changes in this network related to these networks: the cingulate cortex, the orbitofrontal cortex, the dorsolateral prefrontal cortex, and the insula. Okay, the eating pathology. The main note here is that most of the symptoms here are related to bulimia, not related to anorexia nervosa. As we can see here, they didn't do the radial graph here, but they say that inside the text. So most of the symptoms in this network are related to the bulimia nervosa, not the anorexia nervosa. This is also related to salience. In a nutshell, the salience here is biased toward toward the visual and away from the cognitive and language centers. We have the ventral salient system kicking to the ventral default mode network, which is related to emotional processing, not related to cognitive processing. And then the limbic system bringing up rewards for food and other cues. So what is happening here is that we are ruminating about our body image, but having reward related to the visual cues of the food rather than cognitive or other kind of rewards. So there are structural changes and connectivity changes related to this to these structures. The salient system related to the ventral default mode network with the striatum and the ventromedial prefrontal cortex, and then the medial temporal cortex being affected or being kicking out during the reward task, which is the monetary incentive delay task. So the important point here is that this circuit really looks like the addiction circuit. Now they didn't have they didn't talk about addiction circuit during this inside this research paper, but it really looks like it. Striatum and the ventromedial prefrontal cortex. I think that the main difference would be related to the executive function. They didn't talk about the executive function here. Anyways, the sixth dimension they talked about, so we can cut through all of this, is the social fear avoidance. So here they found that the social fear and the panic attacks that are related to these social fears usually are distinct as a brain network from the behavioral and emotional dysregulation network. We can see here panic attack and social fears. It is not related to the general anxiety disorder or the PTSD or the specific fears, which we found to be related in the third domain, in the emotional and behavioral dysregulation. Now, this is an easy one. They had the dorsal default mode network, which is related to cognitive thinking. When we have social fears, it is more about cognitive thinking and overthinking the social cues, and related to the left executive control network and also to the visual and sensory motor networks. So the main point here is that there is no structural functional markers for the social fear and avoidance. It is all about the connectivity through the fMRI. So I'm sorry for all of the neuroscientific jargon, but the research topic is related to this. So the main idea, the result that we have 6 different circuits that cut through our current nosologies and bring us ideas that the brain is understanding some of the symptoms that we are putting together as distinct, and some of the symptoms that we are distinguishing and disentangling in our nosologies, the brain is actually understanding them as the same entity. These are the results. So the conclusions. What are the conclusions of the paper? The first conclusion is that they say that this is the most comprehensive neurobiological research on this data. Previous studies had only 1 to 3 data views, had only lesser components. They didn't have that much modalities in the working. So this is the most comprehensive neurobiological architecture study of behavioral problems and psychiatric problems. The other important conclusion that each dimension they talked about corresponds to distinct brain network, that they are giving us distinct brain networks. They are fleeting away from the comorbidity that we are having in our nosologies. They are saying that the dimensions we are suggesting are distinct, are different, and they are not comorbid as in the current nosologies. The second thing that they concluded that these give us stable transdiagnostic brain markers across disorders. They are saying that this can give us these transdiagnostic markers we have been looking for ages in psychiatry, and this is a step forward in this. The the other conclusion is that there is a potential for multimodal biomarker that these stop, start, task, the different functional tests are quantifiable measures that can help us understand uh, يعني المريض بالمستقبل ممكن ننطيه أكثر من modality of brain imaging وراح يوصلنا إلى نتيجة معينة بناء على هذا الأمل من وجود brain informed nosology. النقطة الأخرى الكونكلوجن إن هم لأنه دخلوا longitudinal analysis ممكن تكون كثير من ال variables that they talked about they can serve as early markers of severe symptoms. وعن من الشيء المهم همين إنه هي population based cohort، فهذا أيضا جيد من هاي الناحية. النقطة الأخيرة إن هم يقولون لأنه هم قدروا أنه يسوون orthogonal statistics، بمعنى أنه السيركت that is related to depressive symptoms is not the circuit related to impulsivity and is not the circuit related to social fear and avoidance and it's not the circuit related to stress pathology. هذا معناه أنه كل سيركت جاي يضيف لنا المزيد من الديسنتاجلينج للكوموربيديتي والهيتروجينيتي، يعني جاي نقلل الهيتروجينيتي من خلال النتائج اللي وصلنا لها ومن خلال الموديل اللي هم وصلوا له. فهذه هي الكي تيك اويز they talked about in the discussion. هسه الكريتيكال اناليسيس بالبدايه يعني اكو مجموعه من الليميتيشنز. طبعا لازم نحيي الفريق البحثي على ان هم الليميتيشن section in their research is extensive. They had many points in them, so all of the black points here are actually from the research paper itself. They had sample bias. هم اصلا واحده من الانكلوجن كرايتيريا مالتهم انه the participant should be Western European، يعني مثلا ماكو immigrants ماكو كذا. ربما رادوا يزيدون الفاليديتي مالت السيلف ريبورت كويستشنير من باب انهم يعرفون اللغه، بس هو اكو sample bias culturally speaking they are all Western European patients. النقطة الثانية اللي هاي هم ذكروها naturalistic design، لأنه هو naturalistic design people coming in يعني with no randomization or anything anyhow. This can miss out low prevalence dementia and schizophrenia in this population. هو أصلا population young، فيعني هو low prevalence بهذا السبب. النقطة الثالثة أنه هو there is no normative baseline. احنا هنا سولفنا من أول نقطة إلى آخر نقطة عن psychopathology، يعني ما محددين شنو الدايمنشنز in healthy controls. حتى من نقرأ بالبحث أنه تعرف هسه هذا الانتيريور سنجوليت كورتكس احسن، يصعد ينزل يكبر الثكنس يقل الثكنس. يعني ماكو نورماليتي، ماكو ستارت ستوب تاسك بهالمستوى هو النورمال. وانما احنا شفناه صاعد هالقد فيصير ويا السايكوباثولوجي الكذائيه، نازل هالقد فهو مع السايكوباثولوجي الكذائيه. ماكو هيلثي كنترول. النقطة الرابعة ان هم نيرو بايو ماركر سكوب، ما دخلوا جينيتك هرمونال اور اي جي الكتروفيزيولوجيكال داتا. طبعا هم عزوها قالوا انه هذين كلهن يتاثرن بال بالتستر او يتاثرن بعوامل كثيره مو مثل النيورو ايمجينج. النقطة الأخرى هي lack of model standardization. ال SGCCA بالرغم من أنه هو موديل يستخدم كثيرا بالنيورو ايمجينج ستديز، بس لحد الآن ماكو فد ستاندرد لكيفية استخدامه. يعني هاي الأرقام اللي شفناها، اللامدا اللي اختاروه، كلها آه، يعني ماكو فد ستاندرد لهذا الموضوع. النقطة الأخرى هو الهاي موديل سنسيتيفيتي. يعني احنا شفنا انه هواي من السمول داتا انشالت من خلال انه تتصفر. مثلا ان هم اذا بالكويشنير احد البارتيسيبنتس ما مجاوب سؤال فهم اعتبروه زيرو سكيب رول. ايش قد هاي ممكن تسوي ديستورشن للريزلتس ما نعرف. زين. النقاط اللي انا اضيفها للليميتيشنز هي انه التارجتس اللي موجوده في البحث لحد الان مو مثل من نحكي بحث عن الدوبامين او عن السيروتونين او عن الكذا. هذين البحوث ينطلنا فد تارجت احنا نقدر نشتغل على تريتمنت عليه. احنا هنا جاي نحكي عن نيورو اناتومي وعن فانكشناليتي اكثر ما جاي نحكي عن تريتمنت تارجت ممكن احنا نستخدمها. ف it is still a descriptive points. النقطة الثانية هي أنه هم استخدموا سيلف ريبورت كويستشنيرز، ما استخدموا انترفيوز، وهذا يقلل من قيمة التشخيصات اللي اعتمدوها ويقلل من قيمة السايكوباثولوجي. النقطة الثالثة هو أنه أكو بايس غير موضوع الويسترن يوروبيانز، وهو أنهم محددين الأعمار بالكوهورتس. يعني ماكو واحد عمره فوق ال 30 سنة. فهذا أيضا يعني حتى الأسترا والستراتيفاي كوهورت الثانية اللي هي مو لونجيتيودينال محددين الأعمار على يونج ايج. النقطة هذه الليميتيشنز. السترينث، طبعا السترينث الواضح هو انه هاي يعني فد اكستنسيف داتا سيت اكثر من 1000 مريض، هواي موداليتيز 7 ايمجينج موداليتيز. السيمتوم داتا موجوده مستخدمين الاي سي دي والدي اس ام سيمتوم داتا اللي هي داتا احنا نفتهم لها ونعرف لها. ان هم بنفس البحث they did the replication. يعني replication independent replication، ما انتظروا واحد يسوي بحث يسوي replication، وانما هم في نفس الديزاين مالتهم سووا independent replication. انهم قدروا يعطونا 6 stable cross diagnostic dimensions traced back to adolescence. هذا امر جيد. النقطه اللي وراها السترينث انه هو البرين نتوركس اللي هم جاي يحكون عنها هي بلوزابل. هم نفسهم بالدسكشن في كل مكان يقولون انه هذا، يعني هم سووا سايتيشن لبحوث اخرى تحكي عن فانكشنز الهاي البرين نتوركس تناسب الحكي مالتهم، فكأنما اكو فاليديشن من بحوث اخرى. النقطة المهمة اللي أنا يمكن أجاوبتها توني، إنه إذا نلاحظ الدايمنشنز الريليتيف كوفيشنت أو ريليشنال كوفيشنت تقريبا بين ال 0.4 إلى 0.12. يعني أعلى شيء 0.4 بالإيموشنال بيهيفيرال ديسريجوليشن، وأقل شيء شفناه 0.12 بالستريس باثولوجي والسوشيال. طبعا واضح إنه ال 0.4 اللي صار بالتست فيز، وال 0.17 اللي هو باللونجيتيودينال فيز، يعني المرضى بأعمار الادوليسنس. زين. السؤال هو هل هاي الكوفيشنت مناسب لو مو مناسب؟ يعني ما تشوفونه قليل انه هو 0.4 او 0.12؟ اذا نقارنه بالنيورو ساينتفك داتا اللي احنا نعتمدها وهو نسولف بها كلينيكالي، مثلا الدوبامين ثيوري مالتها الريليتيف كوفيشنت او ريليشنال كوفيشنت هو 0.37. فيعني الابر ليميت اللي موجود بداخل هذا البحث يشبه الدوبامين ثيوري. فيعني الداتا الكوفيشنتس مالتهم زينه. حتى اللور ليميت اللي هو 0.12 فهو يشبه مثلا السمولر هيبوكامبي ان ديبرشن. فهذا سترينث، معناها هم قدروا يطلعوا لنا ريليتيف كوفيشنت مناسبه للبنش مارك مالت النيورو ايمجينج والنيورو ساينس ريليتد تو سايكايتري. زين. شنو التيك اواي؟ التيك اواي اوكي this is a technically rigorous conceptually bold attempt. It is bridging ICD DSM research domain criteria hierarchical taxonomy of psychopathology, and is trying to unifying all of these models. But in the end of the day, this is clinically limited. This is clinically limited. It is not going to change anything tomorrow in our clinics and for our patients. النقطة الأخيرة اللي أريد أنهي بيها مالت البرزنتيشن هو انه احنا يعني this research paper is not about the data itself. It is about an endeavor people in Europe, in the Western Hemisphere and elsewhere, even elsewhere. يعني احنا اكو توجه واضح ل formulating psychiatry through strict biological lenses. هي الرسالة الخفية بهذا البحث هو انه احنا نريد نسوي نوزولوجي which is biological، على عكس يعني مثل ما كنا قبل مثلا بالدي اس ام 2 هو سايكو دايناميك فورميوليتنج سايكو دايناميك نوزولوجي. هنا الجماعة جاي يطالبون بوجود biological nosology. The broad mission of these endeavors is that we are trying to formulate psychiatric disorders as a strict biological entities. لا بيها phenomenological ولا psychodynamic factors ولا social factors. هاي الفاكتورز مو مهمة، احنا نريد نقسم ونصنف بناء على البيولوجي. طبعا شنو المشكلة الأساسية اللي هي المشكلة المعروفة بالعلوم انه احنا نريد نسوي كوانتيفيكيشن، نريد كوانتيتي لهاي السايكايتريك ديس اوردرز، نريد فد اشياء مور فاليد، اشياء ملموسة اكثر، مور تانجبل. نفسهم الاوثرز في اكثر من مكان يقولون احنا نريد يصير عندنا كوانتيفيكيشن اوف اور سايكايتريك ديس اوردرز. طبعا واضح ان اكو مشكلتين. المشكلة الاولى اللي هي المشكلة اللي احنا نذكرها دائما في السايكايتري و elsewhere in psychological sciences، انه يعني saying that this is only a biological entity انت معناها جاي تتعدى المايند بودي سبليت. ويعني هيك بحوث is not even recognizing the problem، كأنما القضية محلولة والقضية just in the brain ومشينا. النقطة الثانية واللي هي الأهم اللي هي إحنا كلينيكالي بنتعامل ويا المرضى، نتعامل وياهم wholesome as people with يعني with experiences very large and heterogeneous experiences. هاي النوع من النوزولوجي is trying to put numbers to this human condition and it is about يعني كأنما المريض هو bag of biological markers وليس عنده هاي البايو سايكو سوشيو spiritual aspects. فالبحث في حد نفسه هو يعني very conceptually bold technically لطيف، ولكن هو السؤال الأكبر هو السؤال انه هل احنا مستعدين انه نخطو هاي الخطوة ونعتمد بالنوزولوجي مالتنا بدل هاي الطريقة البراغماتية والاكليكتيك اللي موجودة اصلا عندنا بالدي اس ام والاي سي دي. هل احنا مستعدين انه نتجه الى صورة بيولوجيكال بصورة كاملة ام لا؟ فاتوقع هاي هي اهم نقاش في هذا البحث، وشكرا جزيلا.
شكرا جزيلا دكتور عبد السلام على هذا العرض الرائع لورقة إلى حد ما معقدة، وهي الحقيقة أنا برأيي يعني فيها limitation. حتى العدد اللي هم معتبرينه strength هو limitation، لأنه إذا أنت بدك تحكي عن كل السايكاتريك ديسوردر، فعشان تشوف مثلا الأنوركسيا which is rare, you will not see the anorexia in every 1,000 people, and so many other things like sexual disorders, etc. But also age limitation على 30 is very difficult to take as it's but in all sense I personally believe this is a good step towards the stage where we can have clinical diagnosis also confirmed or associated with some form of biomarker to tell us that are we close or too far from what's happening in the brain. We have several professors with us. I will be happy to hear their comments. Professor Nizar,
Thank you, Dr. وليد. Thank you, Dr. Abdeslam, for this very nice presentation. I agree the paper is very, very complex and complicated with a lot of jargon. And there were two ways of presenting the paper. Either the Iraqi way, نخبنها, in 10 minutes you can finish it and present it, or you go through it thoroughly like you did, and you did that successfully. So well done. The other thing is the hospital where this study, the person, the lead author, works at Charité Hospital in Berlin. To us Iraqis, it's an important hospital because our late president, Rahimahullah Jalal al-Talabani, was treated at that hospital and he died there. So it has a meaning for us, that hospital. The other thing is, after 47 years in psychiatry, you reach a stage, and I'm sure Dr. وليد agrees with me on that, you reach a stage where you get fed up with DSM, ICD, and all these things, and you have your own concepts of diagnosis and the way that you are tackling psychiatric disorders clinically. But of course, it is not acceptable everywhere, especially if you want to conduct research, if you want to deal with forensic issue, if you want to communicate with people, if you want to label numbers, F50, F60, etc., etc. So you still have to abide by the ICD and DSM. It's a brave way of trying to sneak out of this classical way of categorization of psychiatric disorders and using dimensions. However, at the end, I will tell you something at the end of my talk that maybe at the end we'll find out that we don't agree with it, we disagree with it. They try to really imitate the neurology model. For example, if I have paralysis of my thumb in my left hand, then it is somewhere in the right side of the brain and so on. But of course, for us, it is very, very early days to talk about this kind of anatomical precision and trying to find out the biological basis. And in fact, the paper itself criticizes itself by saying they only depended on neuroimaging studies. They didn't do circulating biomarkers and other biomarkers. It is true, as Dr. Abdeslam said, that they replicated part of the study themselves, but still, to me, it is regarded as one step. If it is repeated by other centers, by other workers, by other group of people, and they reach the same conclusions, in that case, it's a way forward, and it's a very good replacement for the classical way of tackling psychiatric disorders. As far as هل نحن مستعدون, in my opinion, كلا, it's too early for us to accept these kind of changes. I don't think in my generation, or even in Dr. Mustapha Abdesalam's generation, I think you need more and more before you end up accepting these kind of changes. The last word أقولها بالعربي. ومع الأسف الشديد قسم من المستمعين تقريبا 7 أو 8 منهم لما شافوا التقديم هو فقط بالإنجليزي راحوا، والصور هم الزملاء من سوريا لأنه تدريسهم هم باللغة العربية. يعني آسف، أنا شخصيا أعتذر لهم. اللي أريد أقوله الانالوجي، يعني التشبيه في هذه الورقة أو في هذه الأوريجينال انفستيجيشن هي، وما أقصد بها أي سياسة، أكو أحزاب معينة مو بس بالعراق، يعني في كل العالم أحزاب معينة إلها خط معين، 5-6 أحزاب، كل وحدة إلها خط معين، كل وحدة تشتغل لنفسها، وكل وحدة من عندها سياسة. بس من تدخل بالسياسة أو بالبرنامج مالتهم تلقى نفس البرنامج، نفس الكلمات، نفس السياسات في هذه الأحزاب المختلفة. وبعد 20 سنة أو 25 سنة من هذه الوجوه المتكررة يطلعون جماعة جديدة يأخذون قسم من هالحزب وقسم من هالحزب، يمكن دكتور مصطفى يفتهم، وقسم من الحزب الآخر، ويدمجوها together ويكونون حركة جديدة أو اتجاه جديد أو وفاق جديد. أتصور هذا اللي سووه هذول الأخوات والأخوان، بس مع ذلك it's a very brave attempt. وشكرا جزيلا.
شكرا.
شكرا جزيلا دكتور.
أمين. تفضل دكتور أمين. الصوت بس، صوتك.
يس، شكرا دكتور وليد. وشكرا للدكتور نزار. وأنا فعلا يعني فخور في تقديمك يا دكتور عبد السلام. الحقيقة ورقة صعبة زي ما تفضلوا الأساتذة الكرام يعني. وعندي يعني لو تسمح لي عبد السلام يعني نصيحة صغيرة يعني. إذا في مرات في الامتحانات تطلب أن تقدم paper في هذا الأسلوب، فحاول إنه ما تعقد الأمور في paper زي هيك. خذ تكون social، لأنه مش كل الأودينس دائما بيكونوا psychiatrists. يعني مرات بتلاقي في مالتي بروفيشنالز يعني موجودين، فحاول انه تاخذ بيبر كومن ديبريشن، سكيزوفرينيا، باي بولر، شغلات زي هيك يعني مشان تسهل الامور يعني. ولكن you are absolutely right يعني. from a century ago they were psychiatry started based on neurology يعني. When we remember Freud, when he brought a female patient to the table in front of the students of medicine, he was neurologist يعني. We can't really separate the neurological problems from psychiatric problem. Unfortunately now, what we are facing, and this is the most important point really, that we can't really deal with psychiatric problems without psychosocial problems. That's a fact. Wherever we go, we need multidisciplinary team to work together. We need psychology, we need support workers, we need nurses to be together to deliver what is the most important thing for the patient. So medication is not the only treatment. There are some other forms of treatment which are essential. So we don't need to forget that. But I agree completely with you. I remember in the 80s when I was a junior doctor, we have accumulated the few symptomatology, which is mainly of early morning wakening and diurnal variation of mood. These are two symptoms which we have done a research in Liverpool, and Dr. Abu Saleh, if he is can hear me, he will remember that. We focused on the dexamethasone suppression test, these conditions. And also, we compared it with the most finding of the serotonin level of the brain post-mortem. Can you imagine? And to find these kind of meaning for this kind of work, it's extremely complex. And now, after 5 decades of that kind of research, nothing really has been established so far. You know what I mean? Saying that, there is no doubt, as you rightly said, that some of the groups of the excitability and irritability related to the frontal lobe syndrome, for example, we know that from neurology. But also at the same time, as you rightly said, we see that very written in ADHD. And we know also in ASD and ADHD have been named as neurodiversity kind of development. So I would prefer, honestly, to focus on the things which is more practical in our psychiatric practice. Like, for example, developmental problems. Yeah. There is no mental disorder without developmental difficulties or dysfunctional development until you will manage to analyze all that kind of thing and to group the information from the patients. The same thing happening with the emotional dysregulation in EUBD, for example. Yeah. So these are important things. The other point really, which I want you to be aware of it, psychiatry is not something static. It's always going dynamic. We know, and I am sure Dr. Nazar will support me in this. In the 70s, there were psychoanalysis was a common form of success in psychiatry. And then in the 80s came biology. They were talking about these kind of markers to investigate that. And then the psychoanalysis has been diverted into other forms of therapy like CBT and DBT and these kind of things. So I agree. We have to renovate psychiatry and to practice differently sometimes. I agree with that completely. Neurology is very, very important. But we are the two kind of professions in medicine which we never agree with each other, the neurology and psychiatry.
شكرا. يعني المفروض معنا البروفيسور نصيف، يبدو أنه هذا
يجي ويختفي، يطلع ويختفي.
طيب، أي تعليق من الحضور؟
أنا عندي جملة أخيرة بس.
نعم.
يعني أنا أتفق، يعني إذا إحنا يكون شغلنا أسهل إذا كان أكو anatomical basis for our work، شيء جيد وهذه. بس والله لذة السايكاتري هي في هالفيجنس اللي نتعامل معاها، وفي السبيريتشوال سايد اوف ات اللي ما تقدر تخليها لا على ورقة ولا تكتب بها بالقلم وإلى آخره. This is my point really.
It's that biopsychosocial and spiritual
Yes.
form. I don't think even with the best marker we can leave it. Anyway, الدكتور عبد السلام يعني أبليت بلاء حسنا، ومن المؤكد بأنه يعني نأمل أنك تكون باحث كبير في العراق وتثري العالم العربي في دراساتك قريبا بعد نجاحك في البورد المؤكد. فتوكل على الله، ونلتقي بك في بحث من نشرك ومن كتابتك في هذا الموضوع أو في غيره. دمتم جميعا بخير، نلتقي الأسبوع القادم.
شكرا جزيلا.
شكرا.
شكرا جزيلا. شكرا.